We have not made, Virginia Medicaid has made no decisions yet about the health plans that will be offered in Southwest Virginia, but there are 6 health plans that have expressed their interest in being offered into the Southwest, so therefore they are here. And I'm going to ask the senior person from each of the plans to stand up. And we're fortunate that at least 3 or 4 of the senior executives, CEOs of Virginia Medicaid plans are here, and I'll just run through in alphabetical order. We also have representation from the Virginia Association of Health Plans that represents all the Medicaid MCOs as well as other commercial MCOs in Virginia. Laura Lee Vergever is from the Health Plan Association. Laura Lee, are you here in the back? Okay. First health plan is CareNet, Coventry CareNet. Some people know them as Southern States. I think Sue Molinar is here from CareNet. Sue may be outside. I don't see her in here. Where is she? She's, okay, I don't see her. We also have Majesticare, Eileen Shaw. Now, Majesticare is a new health plan. It's a health plan of Carilion Clinic in Roanoke. They'll be offered for the first time in Virginia in January when we initiate the expansion in Roanoke area. So Majesticare is here. Eileen Shaw, I don't know if she's arrived yet. She's, okay. Laura, okay, thanks for coming, yeah. We also have Megan Padden from Optima Health Plan, Optima Family Care. You may, and you can thank Optima for the refreshments today. So they were very generous in bringing that and making that available today. Anthem, Health Keepers. I think Lori White is here from Anthem, and I don't see Lori, but she's here outside. And Dr. Kit Gordon from AmeriGroup, Community Health, here, representing, he's the CEO for AmeriGroup. And I think last but not least is Virginia Premier Health Plan. Jim Parrott is the CEO for Virginia Premier Health Plan. Their parent is the Virginia Commonwealth University in Richmond. So, have I missed anyone? I think that's it. So, 6 health plans. 5 of them have already been working in Virginia for some time in other parts of the state. Majesticare is the newest entrant to the health plans that are being offered. So, and I'm sure they'll be around outside when we finish up. So, feel free to go by, talk to them, get some of their information, and establish some discussion with them. What we'd like to do today is we're going to have a presentation, and Dan Plain is here. He is working with me on this project as sort of a special projects team. Dan and I have been out working and meeting with providers, and a number of you are very familiar faces since last spring to talk to them about the expansion of managed care, and we'll go into reasons for that and so forth. Mary Mitchell is the manager of managed care operations. Mary's right here. She'll be participating today, and she heads up the staff that actually does the day-to-day operations work and communication with the health plans and with you if you have issues with the health plans. So Tina Weatherford is in the back. She's my assistant, and she's been doing a lot of the logistics associated with this meeting and done a great job of setting this up. At the end of the presentation, we're going to have an ample opportunity for you to ask questions. We have been getting a number of questions from you already. We set up an email list and RSVP. We've had a number of questions, and we'll cite a couple of those. We want to make sure we get your questions documented. We'll be getting back to you with the answer. If we're not able to answer that today, we'll get back. This presentation today is going to be put online, presentation as well as the actual videotape session with some editing will be placed online, so you'll have access to that. So anyway, with that, I'm going to turn it over to Dan and for the presentation, and we look forward to today and your question.
We've been out here a few times, starting in late 2009, to talk with providers and get a feel for the provider community and their questions and concerns. And it's part of the reason why we're here today. I want to thank you for this opportunity. I'm going to try and be as concise as possible to leave as much time as possible for you all. And I did want to mention that all of the information will be on the website at dmas.virginia.gov. Click on Managed Care. The presentation the question and answers, and other information I'm going to reference during the presentation will be available for you to download. We are here today to talk for a couple of reasons. The first is to promote the Governor and the General Assembly's initiatives around expanding managed care statewide, to clarify any misconceptions, answer questions, to listen, and really to explain how managed care works. Enrollment in managed care, or let me back up, enrollment in Medicaid and FAMUS is a little over 900,000 statewide. It's ticked up quite a bit over the last couple of years given the state of the economy. And managed care enrollment is about 531,000 statewide for the Medicaid population and about 54,000 statewide for FAMUS. And those are the populations we'll be talking about today. We hear from time to time, why managed care? And there are 5 or 6 reasons. One of the reasons Brian's going to talk about a little bit later is to build a platform for the expansion of health reform. We are also, for our purposes, is that we don't really have network development capability. Over the years in fee-for-service, we've had access gaps. The health plans, for the most part, have been able to leverage their commercial business and the relationships with hospitals to increase access for members. Quality improvement. Our outcome measures around EPSDT, immunization, and prenatal care on the fee-for-service side were lacking. Our requirements for NCQA accreditation of the health plans have resulted in Virginia having higher quality measures. We require, or DMAS, the health plans require their providers be credentialed. In the past, we've had concerns about certain areas of our fee-for-service provider network. We didn't have a qualification verification process. We weren't able to do site visits. The MCOs using NCQA standards are able to assure that we have very high-quality provider networks. The health plans are also able to provide member services that the department hasn't really been able to develop over the years. In many cases, they have 24/7 call centers. They can develop and provide specific member information, and they have the ability to reach individual members in their homes if needed. The health plans have case management services. We are no longer able to provide chronic care management. They can provide case management. They're able to focus on prenatal programs. Of course, in Medicaid, a large part of what we do is help have babies. And the MCOs can offer, programs to focus on these programs, and they offer predictive modeling and patient-centered care. Additionally, and importantly, is the cost aspect. The health plans are at full risk, so that allows us to assure that we have a stable predictor of cost in healthcare delivery. The health plans also offer, for members and for providers, many additional values. We are one of a handful of states that require that our health plans be NCQA accredited. As you may know, NCQA is sort of the gold standard in evaluating health plan quality. All of our existing 5 health plans are not only meet this requirement, but they are among the top 50 health plans wide in delivering health care. The health plans also have very dedicated provider relations staff, which the department does not have. They're also able to produce and do produce very detailed member handbooks, provider directories, newsletters, health and outreach information that we found to be very beneficial to members and to the provider community. The plans do offer enhanced services for the most part, and an example of that would be adult vision, or vision benefits for adult members. I referenced case management previously. They also have dedicated outreach staff, which can provide member outreach and education. There are 24-hour, 7-day-a-week nurse triage lines for individuals who have questions after hours, provider office hours. They can call the health plan and get advice. And very importantly, I think, and it's something we've heard in our visits out here, the plans have programs to deal with difficult patients, the drug seekers, the high ER utilizers, we call them the frequent flyers. and have programs, again, to help those individuals with chronic diseases. The health plan, immunization rates, we have so many children in our programs. We're focused on improving immunization rates, and those have increased substantially with the expansion of managed care across the state. They're at 83%. The national average for Medicaid is 63%. They have very strong diabetes management programs. Diabetes is a condition frequently seen in our population. And we'll talk a little bit about the differences between, using diabetes as an example, how they're different. With respect to regular Medicaid, fee-for-service, patients enrolled in the fee-for-service program, pretty much have their primary doctor and his or her staff to help them manage their condition. The health plans not only have the physician and staff, but they also have phone-based case management. They have outreach, they do special mailings, they contact the recipient, and they strongly encourage the enrollee to work within the program to assure that their health status is maintained or improved. The map is as visible or as colorful as we would like it, but currently the areas in Virginia that are east of Roanoke have multiple MCOs and have had managed care for about 15 years. And we're very proud of the work that the plans have done in those areas, and it's become very much part of the routine for delivery of health care to Medicaid recipients in those areas. In the region that includes Roanoke and Allegheny, it's sort of between Southwest Virginia and Central and Eastern Virginia. We've had one health plan and Virginia Premier, and as of January 1, we will have 6 health plans for the recipients in that area to deliver care. For Southwest Virginia, which is everything west of Wythe County, we will be focusing over the next 8.5, 9 months to expand managed care and open up managed care as the delivery mechanism for eligible enrollees. I'm not going to go through the counties, but there are approximately, in Medicaid, there are approximately 70,000 eligible Medicaid recipients in Southwest Virginia. About 75% or 45,000 of those people will be enrolled in managed care effective July 1 of 2012. There is mandatory enrollment of that population, and those are mostly children, families, and individuals who are SSI eligible. The population's currently not enrolled in managed care, and it's important for me to say that while 45,000 will be going to managed care, there still will be a fee-for-service delivery system in Southwest Virginia. The remaining 30,000 or so individuals who are in hospice or PACE, which is the program for all-inclusive care for the elderly, who are in the birth injury fund, or those individuals in nursing homes, or who have other coverage, or are on Medicare, will continue to use the Medicaid fee-for-service system. Did I say Medicare? Medicaid, sorry. Again, as Brian introduced, there are 6 health plans that you've probably had an opportunity to already talk with over the last several months, or perhaps met out in the lobby. We encourage you to, if you haven't been contacted, we encourage you to contact those plans and talk with them about opportunities to participate in their networks. There are some services that will continue to be provided by fee-for-service, even after the managed care expansion. And I'm going to talk a little bit about those, but I do want to tell you that I have a handout up here that lays out those services. We call them the carved-out services that we'll continue to pay for. So if you have an interest, there's a stack here showing what those are. There's also the Managed Care Resource Guide. It's available online at our website. It not only talks about the carved-out services, but overall summarizes managed care, what you should look for, how it works, that you may want to reference as you go through this process. The carved-out services that we will continue to pay for are the community rehab mental health, mental retardation, and substance abuse management services, targeted case management for Medicaid only. It's not available under FAMUS. lead investigations, and abortions where the life of the mother is threatened. Dental services, which are through my program, will continue to be delivered by DentaQuest, formerly Doral, and individuals needing dental care, the process will not change for them. Members get enrolled through something we call the Managed Care Helpline, and we'll talk a little bit about that. But managed care eligibles and former medallion enrollees will be pre-assigned to one of the plans that operates in Southwest Virginia in late May. They will receive a letter from the department through the helpline indicating to whom they've been pre-assigned. Those individuals will have until mid-July, about the 18th of July, to call the managed care helpline, to pick another health plan if they want one, if they're not happy with the plan that to which they're pre-assigned, and they can make another choice. Enrollment will be effective July 1, and that includes enrollment for famous members as well. Their assignment process is a little bit different. It happens in June versus in May. Every individual who is enrolled in a health plan effective July 1 will have 90 days to call the helpline, or in the case of Famous, call the Famous CPU, to pick another health plan. After that 90-day period, the only way they can change a health plan is for something we call good cause. The reasons are stipulated by regulation. Rarely do we allow an MCO to change, a person to change an MCO outside of the 90-day period, that initial 90-day period. However, every individual in Medicaid has an annual open enrollment period. That's in May and June for a July 1 effective. So if they want to change, they'd have to wait until May or June to make the change of the following year. Famous enrollees, their annual enrollment period happens on the anniversary date of their eligibility in the Famous program. So that's a little bit different. And that will conclude the first part of the presentation. And we talked, as we were doing this, about the best way to sort of lay out the program and how it works. And we came up with based on our conversations with providers, not only here, but in other areas and expansions that we've worked on, a top list of things that you should be concerned about, that you should look for as managed care sort of rolls out in this region. The system potentially can be more complex, that's true, but there are definite benefits to both providers and patients that we have found to be well worth it. We will be a partner in this process, and we will support the provider community throughout this transition. We'll be having more meetings in this region. We'll be making ourselves available to come out and talk to providers as needed, and we certainly want to work with you to facilitate a successful expansion. And the MCOs, the 6 plans that are interested in the area are listed. Now, what will happen is once we make our selection of health plans for the region, the medallion program, which is the PCP program that Medicaid operates in the region, that will end effective May 1. Individuals who are in medallion will roll out of that program and be in fee-for-service during May and June, and they will be effective in a health plan July 1. If you are a medallion provider, your $3 PMPM that DMAS provides for medallion, the last payment will be in April. In order to continue seeing managed care eligible members, you must contract with MCOs or receive a prior authorization from those plans to provide treatment. Otherwise, you will not get paid. Providers can steer patients to preferred MCOs. You have business considerations. If you have preferred relationships, you can certainly steer your patients. You can post signs. You can send letters to your patients. You can tell your patients that you want them to pick a particular MCO. It's also important that you know the specialty care network. You may find that there are certain specialists that you use more frequently than others, or that you have preferred relationships with, and you may want to align your participation with those specialty providers, if you know it. The health plans have expressed an interest in developing patient-centered medical homes. Talk to the plans about what they may be considering for medical home opportunities. This could provide you with additional benefits that you currently don't have. We encourage you to contract with multiple MCOs. As I mentioned a minute ago, you have businesses to run, and you will talk to the plans and assess what they can provide for you. And we certainly encourage you to participate with as many as possible, but you may determine who you contract with. Each MCO is absolutely responsible for the development of its own provider networks. Their contracts with providers define scope of relationship, claims filing, any sort of business transaction aspect of what you do. Once you have a contract with a health plan, you can see both famous and Medicaid enrollees. One of the benefits that most providers in managed care areas talk about is the relationships they develop with the plans, provider relations staff. They each have dedicated staff, get to know those folks, get to know their names and phone numbers, and they can help you through any issues or concerns that you have. We are looking, as I've mentioned several times, to have a July 1 effective in this region. We have required that the health plans have their final networks to us by December 31st. That's less than 3 months away. We know that many of you have been talking with the plans, may have already signed contracts or in the process. So when the plans tell you the time frame's tight, it's pretty tight. We certainly are making every effort to have this happen mid-year next year, so keep that in mind. Another consideration of the process is that the health plans have require credentialing, which we require, obviously. That process can take up to 90 days. That's something you certainly want to consider as you determine who you want to participate with and when you want to be effective. If you don't contract with an MCO, you won't be able to continue seeing managed care eligible enrollees, and you won't get paid. It's important that you have a contract in place with the health plans to assure that you do get payment. What DMAS has found successful in the past with respect to transition from a regular fee-for-service area to a managed care area has to do with how we handle medical transition. We will support the transition of individuals and providers in fee-for-service to managed care by providing medical transition reports and health status survey information through the managed care helpline to the health plans. This information will assure that patients in fee-for-service or members in fee-for-service who have pending authorizations under the fee-for-service system will be able to get their services through the health plan that they choose. If you have a service that's prior authorized by DMAS, the health plans will honor it when this transition occurs. And this is likely nothing new. As providers, you're already verifying eligibility. We recommend that you continue verifying eligibility through the health plan or through DMAS at every visit. There are a couple of ways you can do that. You can either do it through swipe card technology, or through the internet, or through telephone or telephonically. Again, presentation of an MCO ID card does not guarantee eligibility. Individuals come on and off Medicaid pretty frequently, so you really do need to make sure that you verify eligibility on the date of service. If it's not verified, the MCO is not responsible to cover the service provided. With respect to billing, covered services provided to MCO recipients must be submitted to the MCO. Providers are required to adhere to the MCO-specific contract terms, which I referenced. Each MCO is a little bit different, so you'll need to look at those contracts and see what works for you. Most of the MCOs have electronic claims submission and payment capability. Services provided to a recipient that are covered under the state plan, as it is now, patient cannot be billed for that service. However, if a recipient agrees in advance of the service to receive a service not covered by the state plan, you may bill the member. Appeals, fairly similar for Medicaid, MCO, but for FAMUS it's a little bit different. Providers can appeal with the MCO and exhaust the MCO process. After they exhaust the MCO process, they can come to DMAS. The member can appeal to us at any time if they're enrolled in Medicaid. For FAMUS, providers can only go through the health plan, and members must exhaust the health plan appeals process before they can ask for an external review. That external review is directed to DMAS, and DMAS has a relationship with an impartial entity to review member appeals. A couple of famous differences. Previously, famous benefits in the region are the same as Medicaid. The state plan requires in managed care that famous recipients have very small copays, $2 or $5. That would be reflected on the individual's ID card, and you can collect those at the time of service. And for famous non-emergency transportation, is no longer covered through the health plans. It was covered under fee-for-service, but will no longer be covered through the health plans. We're going to be here for the next hour and a half. We're going to open up the floor to questions, and we certainly want those questions. We'll be establishing a mailbox on our website. Send those questions to us, and we'll respond to those, and we'll be providing those answers online as well. So I'm going to turn the dialogue over to Brian, and I appreciate your time, and thank you all.
We have some mics, some roving mics, and so what we'd like for you to do is give your name and your affiliation with what organization you're affiliated with, and pose your question. We're going to do our best to answer that question. If we're not able to answer the question, we'll get back to you. If we have your name, we can get back to you and do that. This is not going to be the last occasion, for this type of meeting, but we wanted to have one that was 8.5 months ahead of the actual go-live date. One of the things Dan mentioned, the reasons for this, Southwest Virginia is the only area of the state that has not had managed care to this date. One of the other reasons for this, with healthcare reform scheduled for 2014, we expect to see as many as 400,000 new Medicaid members. Not all in Southwest Virginia, but across the state. And we don't know, we can't give you an exact number for this area. I know that healthcare reform is somewhat controversial. Our governor and attorney general certainly have challenging that on a constitutional basis. On the other hand, we are here representing the governor and administration because if in fact it is proven to be constitutional, it's actually going to happen. And I think if anything, if there are any changes to the healthcare reform, we anticipate that at a minimum there will be an expansion of Medicaid. So some of the other provisions may not hold, but we do anticipate that the Medicaid expansion provisions within healthcare reform will prevail. So we are anticipating that. We need to prepare for that. We need a platform, a delivery system by which we can deliver care through health plans when 2014 rolls around. So that's some of the basis for that, for what we're doing today.
DMAS did not make any attempt to restrict the number of MCOs coming into the area. We had previously been told that they would. It's going to be very difficult for a practice to contract with 6 different MCOs, 6 different sets of formularies, all kinds of confusion in terms of pre-authorization and in terms of verifying that the patient is indeed on your list. Can you explain why DMAS did not attempt to restrict that number at all, and how does that compare with the number of MCOs in other parts of the state?
Okay. Dr. Cook, you had submitted your question earlier, so I have your question right here. Several reasons. One is because what we're operating under is a legislative mandate. It was passed by the session last year in the General Assembly session, which mandated expansion in Roanoke by January 1 of 2012 and into Southwest Virginia by July 1st of next year. So we were working within a mandate by the General Assembly and through directives by the governor's office. A procurement process that you're referring to, going through a procurement process, is fairly lengthy because we have to comply with all the procurement laws and regulations of state government. So We were restricted by time. We did not, in terms of doing it in an open fashion or any willing provider sort of approach as opposed to a procurement approach, which would have probably limited to a smaller number of plans. So that is unfortunate. We did not anticipate, quite frankly, in the Roanoke area that there would be 6 plans who would have an interest in expanding to that area. We had one plan operating there then, Virginia Premier. The Majesticare or the Carillion model, the Carillion plan is a very new development. At the time that we started this process, we did not anticipate that Carillion would even be prepared to offer a plan. Things change, and so they are going to be having a plan in the Roanoke area. So, yes, it is. There are 6 in the Roanoke area. How many will be in this area? I don't know. We do not control who you contract with as providers. You don't have to. I'm not sure there's going to be 6 that will be finally offered. That really depends on their ability to contract with you as providers. So if you decide that you only want to contract with 3, then that's your decision. We'll have to evaluate their networks starting in January. They submit their networks. We have to make a determination whether those networks are adequate to serve the population. There's some very unique features of this area, and having traveled it over the last 6 months, very familiar with that. So I can't say how many are going to be offered in this area, but I do want to make sure that you understand that the business decision you have as a practice or as a hospital or as a CSB or FQHC or whichever organizations you represent, that is your business decision, and you make that decision based on what's important to you as a practice or as an organization. We'll have to make a decision on our end as to which plans offer the best networks for the recipients out here. We are very cognizant of the issue that you raised, Dr. Cook, and we're trying to deal with that the best way we can. To some extent, we're working on a mandate which we could not influence the General Assembly, but on the other hand, we're trying to mitigate that as best we can. We want to make sure you understand, though, that the decision about who you contract with, we're not requiring that all 6 plans be offered in this area. That's not our requirement. 6 plans have indicated an interest. You make your decision as providers which ones you want to do business with, and then we'll have to make a decision as to whether or not that's sufficient to be offered in this area. We are very aware of this area that being new to managed care, it provides a lot of complexity. I can't say that that doesn't exist. Dr. Cook has mentioned some of those complexities, but we're going to do our best to try to mitigate that to the extent we can. So we're operating under that mandate. Our job is to bring managed care to this area by July 1st. We need your help to do that. We're going to do what we can to mitigate any the negatives of that. So it's going to be the transition will be, as all transitions are, somewhat difficult. But we're going to put people on the ground to work with the practices, and the plans are very cognizant of that issue. All of them are preparing for that, and we'll make sure you have the decision as to which plans are going to be offered as quickly as we can make that decision, so you can move forward. So,
Sharon Morlock with Wellmont Health System. I have 2 questions. One is, how will this affect retro coverage? And the second one is, you made the statement, if you don't verify the eligibility, the second part of that sentence you didn't read said you can't bill the patient. Please explain.
We recommend that you verify eligibility to determine that there is coverage at the time of service, all right? If you provide the service and you haven't verified eligibility and there isn't coverage enforced, you're not going to get paid. If you happen to provide a service and haven't verified eligibility, but eligibility is there, you're going to get paid. But we don't want you to take that chance. We want you to get the card, verify eligibility, know that the coverage is in force to assure that you get payment.
And you know some of these patients have Tennessee addresses. So are you saying every patient that walks into our facility, we're going to have to check eligibility for Virginia Medicaid no matter where they live?
I'm not saying that, but it's a factor of geography and where you're located. If you suspect that there may be a Medicaid coverage issue, if they're living in Tennessee, they shouldn't be covered by Virginia Medicaid and would be out anyway. I mean, we need to know that. I mean, that's something we need to know. Social Services needs to know, so we can correct that, get them covered by the right state.
in the state before you can get coverage. So these people switch back from Virginia to Tennessee.
That's a problem that we experience in Northern Virginia with Maryland and with North Carolina. And point here, it's something we've dealt with. And you deal with Medicaid now. I would imagine it's not going to be any different when the health plans are there. And then you had another part to your question. I'm sorry.
Some of these patients don't even fill out the application for Virginia Medicaid until they're in the hospital.
Well, MCO enrollment is prospective. So if they are, say they come in January 15th and for whatever reason, concurrently they're filling out their Medicaid application and they're made eligible in Medicaid for January 1, they're going to be covered by fee-for-service. They wouldn't be eligible for managed care enrollment until, and that's in the scenario I described, till March 1st. So if you find that they've been made eligible for Virginia Medicaid, either on the date of service or back, that's going to be under fee-for-service, and you'd bill DMAS directly. And famous is date of application, so, yeah.
I'm Kathy Baldwin, and I'm an LCSW here in Abingdon. Are you requiring of the MCOs that they provide the online verification of eligibility that you have at DMAS? I love that you can call at 10 o'clock at night, that you can get online at 10 o'clock at night and still find out that they're eligible if that's what you want to do. Or I'm someone who doesn't have, I'm a private practice. I don't have a secretary. I do all the contacts myself, so it's wonderful to be able to do that online instead of having to wait on the phone line.
You may still call the same verification number for DMAS, and they will tell you which health plan.
So it'll still be the same online DMAS
Yes, you may still
thing.
use that.
Okay, that's what I wanted to know.
Yeah.
Thank you.
I'm Terry from Dr. Sapper's office. Do we still bill Medicaid up till July 1st? Bill to Virginia Medicaid and not the MCOs?
Can you still bill Virginia Medicaid till July 1st? Yes.
And on newborns, will it be the same as it is now? If a mother is covered with Virginia Medicaid, the newborn will automatically be covered for a year? Is that the way it's still going to work?
This is a little bit different for the health plans that come into your area. If a newborn is born to one of their members, that baby is automatically covered by the health plan for the birth month plus 2 more months, automatically. There's no questions asked.
Okay.
The baby, we hope, what we try to still do is get the baby enrolled into Medicaid so they can continue enrollment. But that baby, even without a Medicaid ID number, will be covered by the health plan the mother gave birth in.
Okay, good, because we have a lot come in with jaundice, and they have to be seen shortly after they're out of the hospital. And you said to check the eligibility each visit. Pediatrics, they come in real regular. Will their insurance still be good from month to month? Like if we check it one time in a month?
Yes.
Okay, thank you.
I know Dr. Kraft is here, and I saw her. You had a question, Dr. Kraft, that you sent an email. Would you like to repeat that question?
From a practicing pediatrician standpoint or provider standpoint, we often, despite every attempt of Medicaid to get kids on the right MCO, will have a family that'll come in and for some reason they've been reassigned to an MCO that is one that we don't take in our offices, or the other thing that happens is that we'll sometimes have 2 kids and the one kid will be on one MCO and one will be on the other. So my question is that I see you have the 90-day period of time where you can change them. If you're beyond that and we run into a situation where we've really got to change that MCO, can we do that, and if so, how?
There are always good cause reasons to change after the 90 days, and you just have to write to our office, and we will look into it.
Can that be done point of care? So you have the family there in your office, and you have the 2 kids on 2 different MCOs, and you'd like to change one to the other.
No, because our enrollment is month to month. It would have to be done so we could change it for the next month.
Okay. So what would be helpful then would be to have that contact number and the person that offices know to call so that they can do it.
When an individual has an issue, they can call the managed care helpline, the 800 number just for managed care, tell them the issue, they contact us immediately.
Okay, and that's true for practices as well?
Yes.
Okay.
We've had practices call directly to our office.
Great. Okay, thank you.
I'm Tony Lawson with Mountain Empire Older Citizens in Big Stone Gap, Virginia. And there's a nest of us from Mountain Empire here who have various questions from our different departments. I'm with Mountain Empire PACE, and you said that PACE would not be included, as a managed or be covered under the managed care organizations at this time. What about other community-based services, the waivered services like personal care, consumer-directed care?
First, again, individuals that are in PACE are excluded from managed care. And there is a system algorithm that shows that the individual is in PACE and the system automatically keeps the person out. For individuals that will come into this area and they become enrolled in a health plan and they have just Medicaid, they're not in a waiver service currently when they go into a health plan. If they then become waiver eligible, that individual will stay in the health plan for their acute care services, but all the waiver services will be still handled by DMAS. Individuals that are in a waiver at the time that we assign individuals next spring, they will not go into a health plan. So it's only if they go into a waiver after their enrollment into MCO.
So will the MCOs then be responsible for referring people into PACE as well as into a waivered service, the other waivered services?
The health plans have all types of resources. They're supposed to refer any of their members that appear to need further outside assistance. They do refer.
Okay, so we should develop relationships as long-term care providers.
Definitely.
We should develop relationships.
Yes.
Okay, thank you.
I want to make sure that Mary Ann, because she, Bergeron, would you identify yourself, Mary Ann?
Yes, Mary Ann Bergeron with the Virginia Association of Community Services Boards. So I would be asking a question or maybe even making a comment about some very specialized services. But when we talk about, and I was sparked by the Mountain Empire gentleman, when we talk about people who are on waivers, and I'm specifically referring to people with intellectual disability right now, there are very few primary care physicians and dentists able to, or even wanting to, address the needs of those individuals. And if they are going to be brought into managed care for acute and behavioral health care, then the panels have to be really good, really accessible, and really specialized, and really must include those primary care physicians and dentists who are used to working with that population, because it is a difficult population. Not everybody can do it or is willing to do it. And I guess this is more of a caution for the HMOs. This is an area, if you haven't been in this area, the geography, the culture, there are a lot of differences that are going to be encountered, and there are going to have to be a lot of concessions made in terms of panels, providers, geographic distances. And I am hopeful that all of these are going to be considered, and so I'm going to turn that into a question. And I don't want to take away from people with serious mental illness, because their primary care providers are also very specialized in dealing with people with serious mental illness. So it all has to tie together, and it can't be hit and miss if you're going to have good care coordination. Am I right? Is that one of the things? Are those things that
you are right.
HMOs and DMAS are considering?
Yeah, you are right, and I think we have spent some time, as you know, Marianne, meeting with some of the CSBs. Lisa Moore is here, I know, from Mount Rogers, and Ron Allison we met with at Cumberland Mountain. So we're trying to, we're sensitive to that issue. We'll be evaluating them based on that. You mentioned dentist as well. You mentioned dentist. We are, as we mentioned earlier, the DentaQuest, which is our administrator for the Smiles for Children program, will continue to provide those services, and we are doing a gap analysis with them now. We should get those results in the next few weeks to determine what the situation is out here as to what efforts they need to make on the dental side to respond to what we think will be a ramp up in the request for dental services, because you have people assigned to primary care physicians. The MCOs are held responsible for seeing the care is delivered, and we expect to ramp up in terms of the demand for dental services. So we're working with DentaQuest on that side. So we're acutely aware of that, and we've talked with the MCOs about it. They are aware of what they need to do on the psych side, on the health side, and then we'll hold them responsible for that as we evaluate their networks.
While I have the mic, could I ask one follow-up? If a person decides on one MCO for behavioral health, but their primary care physician is not in that panel, what then happens? Are they in two HMOs, one for primary and one for behavioral health, or what happens there? I don't know if this is a question that other people have, but are there people in the room who want to know the answer to this question?
Maybe the person sitting next to you may have the same question. Absolutely. Is that a question you would have, Mary? Yes. Yeah. I think there's the question, let me rephrase, ask, the question is, do we coordinate the primary care and the specialty? That's something the MCOs will be charged with, looking at how they can do that, especially in an area where there is a shortage, as there is out here. And that's something that we can, that's one of the things, good inputs for them to hear from you today. That's something that we'll need to work with them on to see how those accommodations can be made, because I think they're clearly, in this area, they have to be those kinds of accommodations on a whole range of issues. That's particularly one of them. And I think they're hearing your message as you speak. They're all here. The senior people are here. So that's something they'll be challenged to try to deal with. Is that helpful, Marianne? Am I responding to your question? Yes. I don't know if it's a good answer, but it's a work in progress. We understand the issue, and we'll have to work through the solution, I think is what I'm saying.
Dr. William Cook again with Nueva Valley Pediatrics. Two, I hope, relatively simple questions. Number one, Bright Futures is now recommending a 30-month visit and has been doing so for some time. Will DMAS assure that all of these 6 MCOs will pay for that visit?
Bright Futures?
Bright Futures recommends it. American Academy of Pediatrics recommends it. The question is, will DMAS assure that all of these 6 MCOs pay for it?
It's a well-child visit that the health plans, they meet the EPSDT periodicity schedule.
It is in the Bright Future schedule.
Yes.
Yes. Not uncommonly in a pediatric office will you have a patient show up who is assigned to a PCP other than in an office. If our office is contracted with the MCO, will the MCO pay if we see that patient?
Most of the health plans do honor that, but you need to call them and just before the service is rendered, just to make sure that, they...
So if the service is rendered in the emergency room at 10 o'clock at night, are they going to have someone to tell me the answer to that?
No, emergency services are totally different. They are honored by the health plans, no matter if the provider is in the network or not.
They will pay?
Emergency services, yes.
And if it is an emergency service rendered in my office, they will pay?
No, we're talking about emergency service in a hospital.
So we're still up in the air about the kid with a strep throat who shows up.
If a child comes to you, they present in your office, and you participate with one of these health plans, but your name is not on that card, you just need to call the health plan and say that you need to provide the service. And they'll work with you.
Thank you.
Is it right here?
I'm Rick Mullins with Wise and Dickinson Ambulance Services, and I have a question for you. We do a lot of critical care inter-facility transports, and in order to verify coverage, would we have to verify coverage in that or in an emergency out in the field? And how would we verify that coverage, or how are those services be paid? Because what happens, we're in a very rural area,
Right,
And
right.
we have to take those patients to trauma centers.
I think on the transportation side, it so happens that on the fee-for-service side, the contract of the broker is Logistic Care. For the most part, 5 of the 6 health plans have Logistic Care as their broker as well. So Virginia Premier has its own fleet of vehicles. So we're dealing with the same broker, and so I'm not sure on the MCO side, is that any different answer than you're using now?
We have a 365-day billing that you can then come back and bill us for it if it was incorrect. So we really want people to get care. I think that's, I think that for Dr. Cook, as he was saying, our goal really is for all of us, and I speak for all of us, is to make sure they get care as quickly as possible. So we don't want to be a barrier to that.
Does that answer your question? Okay. Again, if you have questions that you want to kind of on a one-to-one with the plan representatives, nail them outside the door before you leave.
Brian, hi. David Selig with Community Care Network of Virginia, representing the federally qualified health centers. My question is, once DMAS gets past the contracting phase with the MCOs and the total number of MCOs have been identified, can you talk a little bit about the process DMAS is going to use to do the initial assignments for the eligible enrollees, and then how DMAS will manage the monthly enrollments on a month-to-month basis as eligibilities change over the course of time?
Well, for this area, whatever health plans are chosen, the individuals, and at this time, it's mainly the individuals that are currently enrolled in the Medallion program. They will be given a letter the end of May advising them that a health plan has been selected. Unless they have history with a health plan, and they could have come from another area of the state where they did have some type of history, they will be randomly assigned to one of the health plans that we have chosen to service this area. At that time, then, if they do not call, they'll be given a comparison chart that will show them the health plans that are in their area that they could choose from. And if they don't call, we will assign them to the MCO that we have put in the letter. They do have 90 days after July 1st next year to also change their health plan if they get to one and decide they don't like it for any reason. They may do so. The enrollment is month to month. So if they're in a health plan and on the first of the month they say, well, I don't want to be here, we're not able to change them until the first of the next month. It also, because we have 1 million people that we're trying to administer, most of it is done systematically, and it's done depending on the time of the month that the call is made. If individuals want to make a change for the first of the next month, they must call before the 18th of the month that they're in. If it's after the 18th, then it won't be for another month, because it's just how our system has to gear up and work its assignment process. We also provide reports to the health plans of the individuals that they are getting for the first of the next month that shows them if they have any authorized services, shows them if they have any specialized services, say if they're doing home health or having DME or things like that, so they can contact and continue services and understand the needs of their members that they're getting. Then just monthly, it's as the enrollment comes on. Everybody that comes into Medicaid managed care starts with Medicaid. They don't come in when DSS approves them for their coverage begins with fee-for-service Medicaid. It takes 1 to 2 months, or really 2 to 3 months, for the person to get into the MCO. We're trying to figure out a way to make it a little bit faster, especially for pregnant individuals, because we want them to get to the programs and see somebody for their pregnancy sooner.
LaDonna with Mountain States Health Alliance. You said earlier to someone that ER services will be paid. Now, currently with DMAS, unless they render it a true emergency, we only get $30.
The health plans do the exact same thing. They
Exact same
triage
thing.
using the exact same way.
Okay. The other question is, you had spoke to someone back here about the baby being covered the first X amount.
Birth month plus 2 additional months.
And that's not a retro coverage, it's right off the bat.
Right off the
And that's
bat.
with the MCO or DMAS, whatever the mother has.
It's only with the MCO.
Only with MCO.
Yes.
So if they still have DMAS, it stays the
If they have
same.
DMAS, if the individual is enrolled in just fee-for-service and they have a baby, that baby must get its Medicaid ID number before there'll be any claims paid on that baby.
Okay.
That is not so with the health plans.
Okay.
The health plans will cover the babies born to their mothers for the birth month plus 2 automatically.
So you bill those under the birth mother's ID number to the MCO?
Yes, I believe that's how the health plans do.
Okay. And one more question real quick. Is the payment comparable to what the fee-for-service pays as well, or is that totally different?
Health plans all pay differently.
Okay.
You need to talk with them on their payments.
Okay, thank you.
I'm Shelley Lalonde with Dr. Paul Lalonde. He's an optometrist in Richlands. So we're dealing with not only the healthcare portion, but the materials portion for the, providing eyeglasses for the Medicaid patients. I guess my question is mostly about the logistics of how to go about this. The plans that I've been contacted want a decision right now. They want me on their panel right now. But so how do I need to credential with all 6 to get started? Because you have, y'all are not going to make the decision until after the 1st of January, but they want an answer now. How do we go about,
Tough question.
Okay, and what if the ones I choose are not the ones that are selected? Does that mean we're no longer a Medicaid? Right now we're the only Medicaid provider, optometric provider in the county. So, we don't know which.
Well, I think in your situation, and we've been to Richland, so we kind of understand that. You can always later on you can join a network at a later date. I think in terms of because you are exclusively provided there, obviously you're very sought after, and by signing on with all, certainly you eliminate the possibility that one of those plans will not be selected. You could join at a later date, but I think it depends. You have to make that business decision for yourself as to how much risk you want to take. Signing up with all does protect you from, one of those plans not being selected. You could join later,
but if it's not selected, you're not excluded from that plan. You could join it at a later date.
Yeah. Okay. That would not be the plan's preference. I'm sure if they'd like for you to sign up today. That way you're sort of in the network, but I would have to say, you have to make a decision for yourself. But I think that's something that you have to, consider as you kind of make your business decision. I want to point out that, there's a business decision you have to make in terms of who you want to do business with, and I realize there's uncertainty associated with who's actually going to be offered, but that's something that you have to make your own decision. And also, once you make that decision and we've announced which plans are going to be offered, then you have the opportunity for your patients to steer, to encourage them to make a decision to join a particular the MCO that you have a contract with or you have a particular preference for. So there's a lot there's a lot within your power as a provider to make and to steer your patients to the plan that you prefer or that you contract with. That's something that you need to keep in mind.
Hi, my name is Joyce Palmer with ProMed Home Medical Equipment. I actually have a couple different questions. One of the questions I have, I heard someone mention it, just want to make sure that I'm hearing it correctly. Sure. A patient that has Medicare primary and Medicaid secondary, will that affect them as well, the managed care?
Currently, individuals that are in Medicare will not be managed care eligible, currently.
Eventually, they may we'll probably end up going to that too. Okay, another question I have is, can one of the MCOs deny a provider of being services, deny letting us be contract, if we meet all their credentialing criteria? I mean, we're an accredited organization. We work very hard to do that. You know, we're trying to meet every requirement that is set out there for us.
A health plan has the right to limit the number of providers they have and the types of providers, depending on what their network capacity is. I would say that if there were no providers of a certain type in an area, they would be very happy to embrace everyone. But if they had, say, an ample, I don't know, primary care providers and another one wanted to come in, they may say that they don't want any. We don't usually hear of that, but.
Well, the reason I'm asking is we are in a pretty rural area, but over the past couple of years, the DME suppliers have grown quite a bit in the area. And it just really limits the choice of the patients. One of the companies I've already spoke to, you know, they basically said they would submit it to the board and they would decide if they needed another provider in their area.
Now, with DME, that is true. Many health plans do use national type vendors, and they would have to work with them.
So I think my advice, I think, would be to talk to as many plans as you can, make sure they understand what your credentials are, and, you know, enter that type of negotiation with the plans.
I have already been in contact with all six providers. I've actually only got information from 2. The other 4 have not given me any information at all, nor returned my calls.
Well, they're here. So you need to, they'll hang around, you know, after the meeting. So there's Virginia Premier, there's Optima, Anthem is here, Majestic Care, Karen, you know, they're all here.
Hi, I'm Kim Harris from Merit Medical Group, also in Richlands. And we have 3 office locations, all of which are rural health clinics. And my question is, are the MCOs going to be required to pay us at our rural health rates, or will that be up to each individual MCO?
That's a special payment consideration by DMAS. You will still get an adjustment. You will still file like you normally. You file, what is it, quarterly now?
At the end of the year with our cost report.
Yeah, well, and you will continue to do that. And they take in the health plans, what they've paid, they make the adjustments.
Okay, so we will bill under rural health, still continue to do it that way?
Yes. Rural
yeah, that's
health.
the trouble we've run into with the whole 6 MCOs. We have to enroll each clinic 3 times with each.
No, it'll all be handled the same way you do it right now.
Right,
Okay.
Thank you.
I'm Carla Prophet. I'm the nurse manager with Mount Rogers Health District. And as you all know, we have a large baby care caseload. And by the way, we've had an excellent relationship with Premier and would like to publicly thank them for that. My concern is that the continuity of care of our patients, we would like to be sure that with switching to an MCO that we're going to be able to continue, and if we don't continue the service, what steps will be taken to assure that there is this continuity of care, that the patients don't have a break from us and then maybe be without case management for 2 or 3 months, which, as you know, can be very important with a high-risk patient. So we have been in touch with several of the MCOs here, and I understand our state office has been in contact with some. I would welcome an opportunity to talk to the rest of them, but I would just like to know more about what you see as the quality of care for these patients, to be sure that we'd like to see a seamless entry into whatever happens as far as their management goes.
The health plans work a lot with baby care. We have a representative at DMAS, Ashley Barton, that works directly with the baby care group, and she contacts me quite often, and then I in turn go to the health plans. The health plans have approved forms that you use and things, so I think you're going to find that there's going to be a lot of coordination. You do need to speak with all of them though, and then if you're having any major issues, go through Ashley.
Yeah, I'd like to add to what Mary said. I think as far as baby care, as a result of some discussions we've had out here with the health departments, and Mount Rogers is one of them, because they have a large baby care program. We've been able to, we've really sensitized the MCOs about the baby care program and the importance of that program in this particular area because of the services they provide and the shortage of practitioners. And I think all of them, I know that all of them heard that message, and I know they'll respond to it in different ways, but a number of the health, even beyond Virginia Premier, I know that at least one of the health plans that I'm looking at has a relationship in another part of the state with the baby care program that's been quite successful. So I know that they understand that. They have models in other parts of the states they've worked with, and that's something we'll be looking for as we evaluate their proposals to us. So it's a very important point. Obviously, baby care is because of the type of program we are with lots of mothers and children, that's a critical part of what we do. So we're very sensitive to that issue.
I'm Anna Stevens, the business administrator with Mount Rogers. Another question we have, with our huge number of patients that we have in our caseload, will we get a list of patients and which HMO they will be going to when this rolls out?
We don't usually supply providers with the list of the recipients and where they are, so that's just handled through the verification system. See me after the meeting, okay?
We do want ideas from you in terms of what would make the transition successful, because this will be a very complex transition in some respects. So we want ideas from you. If you have ideas that will help us in making the transition successful, we want to know those, and either today or send them to us later. Talk to us after the meeting. We'd like to know what those ideas are and see what we can do to implement those.
And I just wanted to let you know before we get the next question that I know there were several individuals from the local departments of social services that signed up to be here. Because social services, it's a whole complex enrollment. It affects the people that come into your office and everything. We're going to be giving you very specific trainings. We're going to be coming to your offices. So just want to let you know that, we will be coming and you will know more about how it works for your enrollment of these individuals.
Yeah, I know that one of the regional specialists for DSS is here. I met her. Can't find her now, but I know she's here somewhere, and I know that we're very sensitive to working with the local DSS, local Department of Social Services, as we kind of move through this transition. So,
yes, I'm Judy from Family Care of Chilhowie, and if you could clarify for me the rural health status. We get the per diem rate from Medicaid, and you said it would remain the same. Are we going to be required to contract them with the MCOs, and will they reimburse us that amount?
Yes, you have to contract with rural health centers, and FQHCs must contract with the health plans to enable to see those individuals. The difference in the payment is handled by DMAS.
Excuse me, repeat that, Mary.
The rural health centers and the FQHCs, and to see the managed care individuals, you must contract with the health plans to see their enrollees. However, FQHCs and rural health centers have a wraparound payment that DMAS works with you on, and we will continue to do that.
Okay, so we will bill the managed care organization, and they will reimburse us the per diem rate.
They reimburse you for the services provided.
Okay.
And then you report that to DMAS in your normal reporting.
In the cost report.
Yes.
Thank you.
Mary Ann Bergeron again.
Okay.
You mentioned the training for the DSS departments and workers.
Yes.
And my question would be, and this is very important, for people with any kind of cognitive difficulties, they need their CSB case managers involved in eligibility and in choosing HMOs. And so I would hope that CSB case managers would be invited and welcome to those trainings, and that they be invited and asked to participate.
We'll be having trainings for the CSBs too, Mary Ann.
Okay. Thank you very much.
My name's Cindy Keene from Richlands Home Care in Richlands, Virginia. On the home health part, where we do the prior authorization now through KeyPro, is it going to have to go through the MCO, or is it going to still go through KeyPro?
No, home health is something covered by the health plans. And if you have an authorization in place already on July 1, the health plans will honor that until they can do an assessment to reassess. And if they need to make a change, they will. They may tell you to continue on, but they have to honor the authorization until they do an assessment, their own assessment. At that time, then you will work with them for home health.
And so if you're in home health, you're going to have contract with everybody that's in the area.
Yes.
Rick Mullins with Wise and Dickinson Ambulance Services. And back to that question a minute ago, just on the emergency and the interfacility transport emergencies. Currently, we bill Medicaid direct. Logisticare doesn't accept any emergency billing whatsoever. So who would we bill then for those emergencies?
Would you, because I know, I always see those bills coming to Bill Zeeser. You
Yes.
send them directly to him, and I see piles of those every day. If you would see me afterwards, and let's work on that.
Thank you.
Okay?
Kathy Simpson with Highlands Community Services. My question is in regards to the business decisions that you've referred to in the RFP process in particular. What specific documentation are the MCOs required to provide to demonstrate the network that they have put together in the area?
The end of December, the health plans will provide DMAS, each health plan that is interested in coming into this area, will provide all of their networks in these counties, in cities and counties, and the surrounding area. And then we individually look at every one of them. They send us the ones that are contracted. They also note the ones that they have letters of intent with. Our weight is on contracted providers to make sure that they can, provide services for the individuals in the area. We make decisions based off of that. They give us everything they have.
Okay, but
we get down to the pharmacies, down to home health, we get everything.
Well, my question, of course, comes from a provider standpoint. I am not eager to review 6 voluminous contracts if a letter of intent suffices.
We weigh a contract, we weigh whether a health plan will go in by contracts.
You acknowledge a letter of intent, but there is weight
That's correct.
assigned to contracts.
If a health plan came, one of their submissions was just all letters of intent, and the other one had, or one of them had 3/4 contracted and 1/4 letters of intent, best believe our weight would be to the ones that have contracted providers, because we do not have pure assurances that those letters of intent will become contracts.
Okay, thank you.
My name is Lisa Martin. I'm with Mount Rogers Community Services Board. If the individual has FAMUS, but then they're enrolled in an MCO, targeted case management.
Targeted case management isn't a covered service under FAMUS.
And then if they have transportation, non-emergency.
Transportation is also not covered under FAMUS when they move to the health plans.
Okay.
One thing I'd like all the providers here to think of doing, if you have a few minutes, is go on to the DMAS website, the managed care section of our website. You'll find it over on the left-hand side of our homepage for DMAS. And go on to managed care, and at the bottom of the front page, you're going to see this managed care resource guide. We update this usually about every quarter. It's not updated for this area except to say that it has medallion in it. But I want you to see the type of information that we're going to give you to help you through all of this. It tells you the phone numbers to call for if you need to help your members get transportation. It shows you what the ID cards will look like for each health plan. It shows you where each health plan operates. It gives you a wealth of information, shows you where to go if you have problems and you need to contact a case manager for a health plan for one of your members, or where a phone number to give to one of your patients. So go on our website and get this. It's a tool that we have found that providers that use it, and DSS offices love this one too. They really welcome this. We know we've gotten many comments for providers that have been in managed care for quite some time that this is a great resource tool for them. So please try to go in and take a look at it and see if it'll help you.
Any other questions? I know we're losing a few people, and but we want to make sure that if you have additional questions, the representatives will be here outside. I know that a number of you want to talk with them before you leave. I hope any other questions? We want to make sure there's one right here.
And here's a list of carved out services up here also, if you would like a copy.
Hello, I'm Cheryl Poe. I'm calling from a family medicine group. And what do you do when you are on call at the hospital and you share call with physicians that are not in your group that may be assigned to some of the companies that you're not assigned to, but you're still having to see these patients? What are you going to do about payment, or do we have to get authorizations before we can see these patients?
I think you're concerned about patients that are when you're on call, and you might be there'll be physicians who are not
shared call with other physicians that are not in our
shared
group.
call with other physicians who are not in a particular health plan that you might be in.
Right.
Is that correct?
Most of us are very consistent in how we operate and the way we function, and we understand coverages and covering for other physicians, and our payments would be the same whether they were assigned to you or assigned to another primary care physician. Wouldn't be a problem.
And I just want to underscore what Megan said earlier and what Jim was just saying. Our job is to get care to people. So we're not here to create barriers for you. We need to help the state run a program which is sustainable and improves quality, but at the end of the day, it's about getting care to people.
And I think the other point that we all recognize is that healthcare is local. And so we, again, not to do barriers, we know that even in the very beginning it's confusing, and that what we recognize is that sort of the dust has to settle, and it's amazing how after about 3 to 4 months, it just runs normally, and it has a very minimal impact. We're interested in quality, we're interested in engaging you and helping our members get primary care homes. We work with physician extenders in the offices. We allow PAs and nurse practitioners to also see patients and be panel to patient, have patients panel to them. So I think we're all the same. Again, we want people to get care at the right time so that, again, they avoid that ER and avoid that inpatient admission.
Okay, I hope is that helpful? Yes. Okay. Any final questions? We don't want to cut anybody off, but we want to make sure you get your questions answered. This won't be the last opportunity, but we're here now, and the plans are all here. So if there are any other questions, if not, we want to appreciate your coming today. You had some great questions, and we look forward to working with you. If you have ideas for us, please share those with us. Thank you.